All right. Well, thank you everyone for being available after hours. Thank you for the humor, Meredith. I am so happy to present to you today with my friend Geoff Soyiantet about our relationship in the community and what we've been doing over the past year and a half. And so Meredith told you the very long title. It's the official title, but long official titles are hard to fit inside of the little box on the slide. So we get the abbreviated title. So we're going to talk about academic community partnerships. The objectives for today are to discuss a framework of community engaged research. We are going to use an example, and it's going to be our personal example to highlight the challenges and benefits of community-based participatory research. And we're going to share examples of COVID outreach and education related to this and similar models. So I have no specific financial disclosures for this talk, but I did want to mention that the research we're discussing has been funded by the Institute for Public Health and the Gephardt Institute for Civic and Community Engagement. So thank you to both of those institutions for making our collaborative work possible. I also wanted to mention that some of the slides and the figures are borrowed or adapted from resources that are readily available. One is at the WashU Medical Library and their site for community engaged research in practices resource site. And then the other one is that there have been some adaptations to lectures that were sponsored by the Center for Community Health Partnership and Research at WashU. So thank you to Polly and Dr. Sanders Thompson for that. So remember, we're going to start by just talking about in general community engagement. And so we're going to go through some definitions. I call this the boring part, but essential part of the talk. We'll go quickly through it and won't get too tied up in the details because the important stuff is how this is applied later. Community engagement generally is defined as a process of inclusive participation that supports mutual respect of values, strategies, and actions. Where community is defined as geographic proximity or neighborhood, special interest, or similar situation. Community engagement acts to address issues affecting the well-being of the community of focus. Community-based participatory research definition is a collaborative process that equitably involves all partners in the research process and recognizes the unique strengths that each brings. It begins with a research topic of importance to the community with the aim of combining knowledge and action for social change to improve community health and eliminate health disparities. So we're going to talk about the continuum of community engaged research because there are multiple ways where there can be community engagement, and one is not better than another, even though it's represented by a continuum. The continuum represents on the left part of the screen where the community is least engaged, and then on the right part of the screen where the community is more engaged. So again, I'm not here to judge what's better or worse. I'm just going to take you through the continuum to give you some examples of how this might work. So there is something that is defined as non-participation, which we're not going to talk too much about. It's basically where there is an outreach project. It's designed by a researcher or organization, and it's implemented in the community. The next step along the continuum is something called tokenism, and we're going to talk about two types of tokenism. So the first one is called coordination or consultation. So it's where the researchers gather community stakeholders together to assess important elements of a project or activity. So kind of like a focus group, the members will give feedback and that informs the researchers' decisions. But then when the researchers go and design and implement the project, they don't use the community to help with that. The implementation is ultimately done in the community, so community members do benefit from this, regardless of the lack of cooperation. And then cooperation is the next phase where researchers ask community members for help with the project instead of just asking for their advice or opinion. So that may be that they help with recruitment or giving out surveys, measuring things, so that the community is involved in part of the research process. As we move further along the continuum, the next step is engaged participation. And then that starts with collaboration. So collaboration is when patients, caregivers, clinicians, researchers, and community members partner in every aspect of the research. So that includes setting priorities, study design, implementation, analysis, interpretation, and dissemination. So community members and clinicians collaborate in the decision-making, and they share resources throughout the study. The collaborations are built on mutual respect and trust, with all partners being valued. And then finally, at the final end of the continuum is a partnership. And so instead of just collaborating on one project, this is more where the longitudinal relationship starts and continues. So I wanted to give you an example of community engaged research, and we're going to talk a little bit about today about what I've been doing as a representative physician from WashU, and what Jeff has been doing as a representative of Vitendo4Africa. To take you on the timeline of our relationship and how we have been able to form our partnership and go through the whole research process, I'm going to take everybody on a little bit of a time travel. And we have to go to this really strange place called pre-COVID in order to visit that. And I know that not everybody remembers what happened pre-COVID, but things did happen actually. So our relationship, Jeff and I, started in the winter of 2019, where there was a formal introduction by email that happened actually with Polly Rios, who said, hey, I think that you and Jeff might have something in common and might want to partner together. And so that's essentially how it worked. I had met Jeff before at ISPN meetings, but other than just simple discussions, had never actually talked much aside from that. And so this was sort of our formal introduction to becoming true partners. This went into the spring when we applied for our first grant after talking, and as most grants go, we were rejected. So we didn't get our grant. And so we were quite sad about that. And then this amazing thing happened where the Institute for Public Health, where we were applying for the grant, said, you know, we kind of like your idea. We think it's a good representation of how academic institutions and communities really should be performing research. We have this separate set of funds set aside. We would like to offer it to you if you put in your proposal again. And so we essentially put the same proposal together, and we were able to get funding for our pilot program, which we had, which I'm going to tell you about in just a moment. So we were able to secure funding by the fall of 2019 and implement our project. And we actually finished up in February 2020, which was, again, if you remember, right before COVID. And that's actually important because of the way that we did our project. Our relationship continued even though we finished our project. We applied for another grant. We thought that the relationship was worthwhile, and so we applied for another grant, and so we were able to get that accepted. We actually had another grant rejection in the middle there. So we, at that point, had applied for 4 different grants together. And so currently, over the summer and the fall of this year, we were able to form a community advisory board. We're doing our project, which I'll tell you about in a moment. And we actually had plans to expand our project aside from just doing tuberculosis education to expanding it to other health issues that impact the immigrant community. Okay, so here's our project. So the purpose of our project was to educate the immigrant communities about tuberculosis with the goal of diagnosing and treating latent tuberculosis in high-risk communities. So this is not supposed to be a health talk, but there's one very important thing that I should mention before I move on, and it's that 2 things. One, tuberculosis is very common, and specifically latent tuberculosis. In fact, 2 billion people estimated globally have latent tuberculosis. So it's about 1/4 of the population. The second thing is that there are essentially 2 phases of tuberculosis. One is what we call latent tuberculosis or sleeping tuberculosis. It's where the infection is not contagious. people do not have symptoms and you're not contagious. It's sort of an infection living in your body that could reactivate at any time. And as it turns out, sometimes it does. And so it doesn't in everybody, but it has basically a 10% chance of activating at some point in your life. And so that becomes what we would say active tuberculosis, or what's called tuberculosis disease. So the whole point of TB care is to treat the infection while it's latent or sleeping before you develop symptoms. Because when you develop symptoms, it can be a problem. Treatment is more complicated and it carries a high mortality rate even with treatment. So that's all I'm going to say about the medical stuff. All right, so the mechanism of our project was to train community members, which we called facilitators, or what is sometimes referred to as lay health workers. And we wanted to train them to educate their own community members in the home. So again, remember this is pre-COVID. So we essentially trained people about the basics of TB. We trained them about leadership and how to run groups. And then we had them recruit people in their community and invite them into homes where they would then educate their community members on TB. And the way that we measured this, because most good research proposals should have some way of measuring, is we had a test. So we gave the members that were involved a test before and then after the sessions. And the other thing that we did is we had a survey. The survey was both kind of a satisfaction survey to see if you liked or thought this had value, what you were doing. But we also had this very important question about self-efficacy. And so related to TB, that was, after you have learned this information, how likely are you to go and get a test for TB? And that's really important because, as I mentioned, this latent phase TB does not have any symptoms. So you don't really know until you test. And we know that foreign-born individuals are higher risk. So that's why we're implementing this program in an immigrant community. To give you some of the project details, the training session that we had, and we've now had two, was a one-day full training session for facilitators. Then the facilitators would gather participants and meet in the home. And now, since our project is continuing, this is mostly a virtual platform. And then we formed a community advisory board. The community advisory board has been a great addition. They actually have helped to make decisions of funding allocation, and they're going to be helping us with future grants. In the current grant that we have, there's a lot of flexibility as to where the money goes. And so Jeff and I thought that it would be important that it wasn't just two people making that decision as to where the funds should go. So that's why we have the board to help guide us. We thought it was a more equitable way of delivering the funds. The education sessions for the participants are split into two separate sessions. They typically take anywhere from 1 to 4 hours. It just depends on the group leader and the format, but it is designed to be two separate sessions. And then we have a plan this time to partner with the health department to offer TB screening. I am going to let Jeff step in and talk to you about sort of from his perspective as a community organizer and an organizational leader about how the sessions were run, in his perspective, and also how the home sessions went, because he was actually a witness to some of them, whereas I was not. I was there at the training, and so here you see pictures of our training, one pre-COVID, one post-COVID. So very different formats. And then this is, again, pre-COVID educational session performed in the household. And so I'm going to let Jeff step in and take it from here and talk a little bit about things from his perspective.
Yeah, thank you, Dr. Prater. Yeah, is there echo? Like Dr. Chris says that we had a great training that when we were conducting in people's home, we also realized that it was easier to get feedback because people were more comfortable to open up, and in an environment where they are very comfortable, people they know, they didn't have to worry about who we are, because the people we are training, they're part of the community. People trust them, they have great influence in the community. And you actually coming to them at the time when they actually, like most of these forums will be, people meet at fellowship home, people's home for fellowship. So as we tell them to be able to protect themselves through prayers, it was easy also to educate them why they also need to take physical precautions so that they can be able to be safe. And it was very good to see a lot of them, especially those who could not read, even if you supply them information, written material, then are not able to read, they will be able to ask questions in a language that they can understand. The fact that we have people in the community who speak their language, who also have understanding of some of the cultural barriers that affects the treatment process. So it was very easy to communicate and talk, addressing those areas. And a lot of people were very positive, and especially asking questions in an audience, with the fact that most of them have a big negative notion about TB, and those who are hiding to talk about it and not maybe going for tests. We found this can be a very effective way to communicate, to educate the community, not just for the tuberculosis, but also for any other, most of other diseases that are, or other challenges that are in the community. Right there.
Okay, thank you, Jeff. So Jeff is going to talk a little bit later as well. So I don't have anything more to add about that. I think that I've really enjoyed the way that we've designed this project, and I'm glad to hear his insights as well. So to talk about some of the partnership details, what specifically happened, something very interesting, is that Vitendo, Jeff, and one of his advisory board members proposed the initial project. And he basically said, you know, Chris, in our community recently, we've had some tuberculosis cases, and we've even had some of our community members die recently. And so this is a really big problem in our community. How can we work together to improve this? So the problem and idea stemmed from the community. And so that's sort of what sparked our interest and in our proposal. And at the time, I had a grant where I was looking for an idea. And so it really, the timing worked out very, very well. And so that's how we started our partnership. So we designed the project together once the initial problem was put forth. Vitendo helped to recruit the facilitators and then helped with recruiting the participants, the people that were being educated. WashU, between myself and a student that was working with me, we were able to prepare and submit the IRB for research approval. Vitendo then oversaw the education groups and helped to collect the data, which was then handed back off to WashU, where we analyzed the data, and then we were able to share that during one of our meetings. And we can use that as a platform to apply for other funding. And then, you know, as a representation of our true partnership, we both created the slides of this project. So this has really been a good partnership. I only speak for 50% of the partnership, but I'll let Jeff continue in a little bit. The other thing I wanted to mention is that This is not a talk about the results of our project, but the other nice thing is that we were able to demonstrate efficacy of our project. Not only did our participants gain in knowledge quite significantly from the pre-test to the post-test, but that self-efficacy piece that I mentioned, where, you know, patients or participants were supposed to say how likely they were, what steps they would take for TB testing. A vast majority of the ones that really needed to be tested reported taking initial steps to get tested. And that's something that's really important in public health data. So how did this partnership work and how does it continue to work? So these are just some initial thoughts that we had. So first of all, it's mutual respect. And that's really how any partnership works, but it doesn't need to be stated, but it's very important. And I think the other thing that goes beyond that is mutual admiration. So, you know, I think that we both do a good job of admiring each other's work in our respective fields. And so that sort of adds another layer of the respect. Patience, this is not a fast process when you have more than one organization that needs to be collaborating, especially when one of them is an academic institution where things actually move very slowly. A great deal of patience is needed. And having open discussions about each person's role, so knowing who's doing what is very important. I think it would always help to have common goals. It's not really necessary, but having a common life purpose, I think for our partnership has been very valuable. You know, we really are dedicated to improving the lives of vulnerable populations. And so we have this personal level similarity that I think helps drive us forward here. So again, it's not required in any partnership that you have that level of similarity, but it helps. And all of these things make our partnership work. There are always some challenges. So first of all, meeting times with facilitators and board. I mean, this is a big challenge, right? Many of the people in the audience are in or running organizations. Like, how hard is it to have meeting times? And especially in the immigrant community, and in particular, some of these facilitators are leaders in their communities. So they might have two jobs. One might be a night shift. They have families. And in addition to all that, we're giving them this extra responsibility. So it's very difficult actually to come up with times, but we make it work. The other thing is whenever you work with an academic institution, getting through the IRB process can be a hassle. And the other thing is that whenever anyone is involved in obtaining consent for a research project, they need to be formally trained. Which is like a research ethical principle. And that training itself is a lot of time and effort, and it requires capable use of technology. And so some of our facilitators really struggled to get through some of the IRB process. I won't focus too much on that, just it was a challenge. And then funding is always an issue. I think that everybody here can say, like, funding is never automatic. It always requires extra work. And funding in particular with community partnerships it's a very specific type of funding that you're looking for. And so, you know, the nice thing is that we haven't had many challenges related to personality or social cultural differences. So again, going back to the previous slide. This is my favorite slide. So the benefits of working together. So, you know, educating a community, how great is it that we can really make an impact? This was at a micro level, but we have plans for scale up. Improving the health of the community. I mean, that's what I mentioned when we have that goal, that drive and that worldview. That's what it's all about. And then, you know, establishing a true partnership, right? So when you establish a partnership, you not only are helping with that one project, right? You have a longitudinal relationship. You can build on each other and make a greater impact as time goes on. As representatives of our institutions, so Jeff and Chris, you know, we also can help establish a relationship and a partnership between our organizations, so Vitendo and WashU, right? So as individuals, we are advocates and representatives of those organizations. And as the organizations are actually more powerful. And so, but we helped a little bit to make that work. Okay, so what about coronavirus? So we're gonna make a real big switch here in topic, but it's very important. And we thought it very timely to include here. So the one thing that I will say is that in our new batch of facilitators, we have been educating them on the basics of COVID. They will then pass on that information to their groups. So not only TB, but another, which is another pathogen that spreads by respiratory droplets. And so they're going to be educating people about COVID, and they're not only going to be doing this with their words, but also their actions, right? These community facilitators are going to be seen as role models. So we'll want to make sure that they're practicing social distancing and doing safe education. So, you know, virtual sessions, or when possible, distance adherent in-person meetings. Not very possible right now. It's not good in a surge, but as advocates, they're going to be demonstrating proper precautions. Now we're going to leave it back to Jeff to talk about more about what he and his organization have been doing involving COVID.
Yeah, thank you, Dr. Chris. Like the previous presenter, I think Kerry Mayer mentioned 15.4 million people or immigrants who are excluded from stimulus. It also means that a lot of them actually are working in areas that are more exposed to public. That includes people working healthcare, people who work in drivers, those who are working in restaurants. So a lot of our population that we serve, actually, they're more exposed to the coronavirus. And I think at the beginning, when it started, I think people were, without more information, many people didn't take enough precautions. So we kind of get quite a number of them were affected, and we lost a couple of them through COVID-19. And the biggest challenge also is because of the fear of them going to the hospital. I mean, going for the test. If you're tested, then you have to quarantine. And if you're the breadwinner, that means the family is not having any income coming. So we've realized most of them are not even actually willing to go for the test. They would manage the symptoms, but still go to work even with the symptoms, which means there was risk of spreading the virus to other to the population, to the other people, just because of that fear of if cut off the income, then the family will suffer. So we jumped into reaching out, using different means to be able to educate them. Distributing of materials that are with the language they can understand. We did the Zoom meeting, but mostly we also had a training more for the community leaders so that they can be able to use that information to communicate to their community. And I think, just to mention, there are different languages, more than, I think, 2,000 languages speaking in Africa. But when we use a model that we have we are working with Dr. Prater, we have people who can now be able to go to different community and talk and train to people, not just tuberculosis, but any other common diseases that are there in our community, or any other issues that are there in the community. And I know I see Signal, we just have a few minutes. I think from that time, we have seen a lot of big changes. And I think we can go to the next slide. We've seen a lot of big changes out of the training, and also distribution of the mask, because that was a big challenge. People didn't, you may tell people to take precautions when they go to work, but if they don't have masks, that means they're not able to take enough precautions. So we, through the partnership with St. Louis County and STL, we were able to distribute, prepare STL, we were able to distribute, I think right now we have to around 10,000 masks right now. and through different model text message, phone calls, and also one-on-one, we reached more than 10,000 people. And also providing educational resources in different languages through the same thing, partnership with the Prepare CL and St. Louis County. We've hosted over 21 virtual conferences, and that will be different groups, leaders, pastors, youth, and also in March, in the month of May, we also had a public speaking contest for the middle school students in a way that they would record and do a research and do a presentation about COVID-19. And that helped also to communicate because the parents were involved, the videos they prepared, the presentation they did, we were able to reach out to so many people. To encourage people to stay healthy, we organize different programs that includes outdoor activities. And we had a biking club, people who go meet the park and do walk. We by the end of September, we had around 70 people who are involved in different activities. And those platforms also helped us to communicate to people and educate people about COVID-19. I think that's it. I think we have 5 minutes. I don't want to talk too much. Go ahead, Chris.
You did great because we're at the last slide.
Yeah.
That's great, Jeff, with the COVID work. So in conclusion, community engaged participatory research can help researchers, it can help community organizations and community members live healthier, happier lives. Great. It can result in longitudinal relationships that benefit all parties and make future endeavors stronger and more impactful. And I'm going to turn this presentation upside down because we're going to end where we started, and it's going to be the title. And what I think the title really should be is Academic Community Partnerships. Getting it right isn't easy, but if you approach it with patience, humility, and openness, you might just succeed in making an impact in the community.
How large is the community of African immigrants in St. Louis, and how many have you been able to reach? And are you, well, you want to start there? Or I don't know if you can read these two, Jeff. And are you working with smaller segments by language or nationality?
That's a good question. And I think it goes back to the same question people ask, why did you start Vitendo4Africa when there are so many organizations that works with immigrants and refugees? And I say they are different, unique. The African immigrants and refugees have different, unique. And I think even before I started, I did my research and I found the best way to do it is to come up with an organization that will be able to address the unique needs of the community. When I put together the people that was working, I found that we are talking to more than 20. Right now, we're reaching around 22,000 African immigrants, but the potential that we are now able to reach is probably more than that, double that number. And the way it works for us, because we don't have enough capacity to reach out all this community, we use the same model that we're working with Chris. We work with people of influence in every community. Congolese, we have people that I know that are influenced, so we kind of use them to be able to communicate to their community. We have pastors that have very great influence in every community, and those people give us a platform. We're able to reach out to every small community, and especially when there is a difference of language. There are people who can speak that language, so we kind of bring them into the training and provide them with resources that we have. The resources that I have, the information that I have, I'm able to say I duplicate myself in every community so that we're able to reach out all of people. So the other question was, are you working with the, yes, I think that's the same. Yeah, we work with small communities and small segments to be able to reach out just to the larger population.
We have a couple questions left. We are at time. How about we'll take just a couple minutes and try to answer just a few of these. How many people have you reached? How many people have you reached? How many TB cases have you found?
So I can take this one. I'm also like finally catching up with the chat. So unfortunately, it sounds like the sound wasn't working well. So hopefully my sound is better now. In our first project, we reached out to 65 individuals. And so while that's not really that much, this type of project has an immeasurable snowball effect where starting the conversation in a small group, then they will reach out and talk about what they learned with their, families and other groups. And so we have no way of measuring that, but specific to this project, it's 65. So the second wave of the project is ongoing, and we will be doing a similar number. But one of the things that Jeff mentioned is that we're actually expanding our ethnicity in this one. So so in the first study, we did mostly Kenyans and Congolese, and so now we're branching out to some other African communities. So we hope to sort of, even within the African community, diversify our platform. How many TB cases have you found? So the study did not measure whether or not they had a positive test. And so that is actually part of this next cycle. We would assume that there were people that tested positive, and since they didn't have symptoms, would have been latent TB. And then we would have hoped that they would have been treated, as they mentioned on their surveys. We didn't measure that, but maybe for next year.
Yeah, and I think that just to mention, there was one case, maybe could be out of the people getting the importance of being tested. We had one case that somebody was, tested positive, but I think she's out of now. She's now out of the treatment now.
Let's do this. What we're going to do is we're going to launch the poll. We have an end of session poll that I want to launch. And then what I'm going to ask is that we have a couple more questions. And so if you want to stick around and hear the answers kind of like you would at a normal conference, go ahead and do that. If you need to go take a break, also go ahead and do that. So we will be back here at 5:40 to start. We're going to try to just wrap up these questions real quick. And you can take the poll while we answer those. Presenters, just a few more. How are community leaders and facilitators recruited?
I'll let Jeff handle that.
Yeah, like I said, the way it works for us, I look at somebody who has a great influence in the community, because the way to put it is that these people have already doing it. They've been the same people who communicate to people, educate people about what is happening around. So they're kind of already doing it, but it was very informal. Now reaching out to them was very easy, because you already know people who have been there, who already people always go to for information and ask them for any guidance or any help. So they're kind of already there. So and people trust them, people know them. So it was very easy. It becomes very easy to pick up and identify some of the people who can fit in as a facilitator.
All right, and last question, are you looking for any volunteers? The question
Yes.
Everybody wants to get, or maybe not. Are you looking?
We need a lot of volunteers, Yes, we need. And I think I would just mention also, it's also a great opportunity for not just the Africans, but also the Americans to be able to use this platform also to learn more about different African culture and integrate in the community. Right now, we're trying to promote diversity in our region, and there's no better way to get yourself immersed into the different culture than this platform that it gives you that platform to be able to do that. Yeah, we need volunteers.
And I'll add on. So add on one thing, and it's that Jeff just alluded to, and I usually have at least one student with me, and it's really, you know, the students really get to see something cool that is not usually seen at WashU, and so I'm happy to provide that platform. The thing is that WashU students tend to be like way smarter than me, and so they actually very much contribute to the project, and so. And unfortunately, the student that we had this year, she had kind of a family emergency, so wasn't able to attend the training. But you know, to be a part of it is really exciting, and I know that it's really good for the students to see that.
I'm going to ask that you gentlemen put your contact information in the chat if you'd like people to get a hold of you for volunteering. I know it's right now it can be challenging to get a hold of people during COVID. So maybe the best way to get a hold of you there in the chat, and maybe put it towards all panelists and attendees. And in the meantime, I'm gonna take a 4-minute break for myself and for the rest of our panelists. We will be back here at 5:40 for our 3rd session. We'll see you then.
Thanks, Meredith.
Thank you.
Thank you all so much.